So let's start. The study also has no conflict of interest related to the study. Well, introduction, urethral strictures are the most common reason for clinical admissions in urology. These strictures come in the 4th number in ranking about the urogenital problems. And they have a significant negative impact on quality of life and financial burden related to complications. One of the most common treatment modality for urethral stricture is directly visualized internal urethrotomy. This is a procedure we used to do for anterior urethra and for BMJ strictures, bulbo-membranous junction strictures. So my study was totally exclusively for bulbo-membranous junction urethra, especially the anterior urethra, not for the posterior urethra. For posterior urethra, we don't call it stricture, we call it as stenosis. So for the study was basically conducted for anterior urethra and especially for BMJ strictures, bulbo-membranous junction strictures. High rate of recurrence are associated with DVIU. Well, we'll talk about the corticosteroids as my study is basically concerned about the steroids. Steroid therapy is an emerging and prominent solution of recurrence as they decrease scar formation by reducing collagen and glycosaminoglycan synthesis and expression of inflammatory mediators. Well, this is the pathogenesis and mode of action of steroids, which usually act on the corpora spongiosum, where the scar stricture is placed. After DVIU, we put the patient for long-term steroids. I will tell the protocol in later slides, and we'll see how these react and how these patients follow to us with the minimal symptoms. Secondly, corticosteroid therapy is not yet established. There is no such recommendations in recent guidelines. I have studied 2021 European EUA guidelines where there is no such type of treatment is advised for the patient coming with anterior urethral strictures post-treatment. Intralesional steroid injections have shown to provide beneficial results after internal urethrotomy. This type of treatment after direct internal urethrotomy is recently been established, and there is a big recommendation for intralesional steroid injections. The role of oral steroid after direct internal urethrotomy has to be established. This study will provide guidance regarding easy and convenient treatment option for preventing stricture recurrence, which will further decrease complication and improve quality of life. Well, my objective was to determine the efficacy of oral steroid after DVIU to reduce the recurrence rate of urethral stricture. Well, efficacy in terms of, I have calculated efficacy in terms of symptoms in my study. In Eurocon, this paper was same paper was presented in Eurocon in 2020. Multiple question was raised about my study and especially the efficacy. Like you have calculated efficacy on symptoms. Is there any criteria or something else? We'll definitely discuss later on if some type of questions raised by the audience. Material and method, studying Department of Urology, my great department, Armed Forces Institute of Urology. The study design was a randomized controlled trial. Sample size was 180 and sample technique was non-probability probability consecutive sampling. Study duration was 3 to 6 months. So I have written 3 months is 3 to 6 months. Efficacy was defined as no recurrence of stricture at 6 months post DVIU. For study, we have a selection criteria in which inclusion and exclusion criteria was made. Obviously, the male gender, age 20 to 60 years, diagnosed with urethral stricture mostly 45 to 60% of the patient with BMJ strictures, bulbomembranous junction strictures. Then exclusion criteria: patient with following conditions like post-anastomotic stricture. Patient which was initially diagnosed with a urethral stricture, then he had been in surgery for urethral strictures like resection, anastomosis, and augmentation. Then patient ended up with a stricture or complaints with the voiding or irritating blood. Such type of patient was excluded. Then post-URP strictures, most common complication which after most of the patient encountered with post-URP strictures after 3 to 6 months, anterior urethral strictures and posterior urethral stenosis. And obviously the neurogenic and neuropathic bladder, such patients were excluded. Patients with a history of steroid use were also not included. And patient with extravasation during optical internal urethrotomy. During the procedure, when we cut the scar deep into the ventral and ventral aspect of 12 o'clock, then after deep cut there is a bleeding of urethral arteries and arteries and branches of the urethral arteries bleed. Such patients didn't include in the study. So patients definitely who were lost to follow by encountered many of the patients they didn't came with the symptoms to be followed or enrolled in the study. So 180 patients randomized into two groups. Group A 90 patients and Group B, both of the patients were underwent DVIU. Then post-operatively, Group A patient received care. Obviously, the symptoms, monitoring of the symptoms, plus 6 mg oral steroid. Prednisolone was given 6 mg for a period of 3 months. Patient was followed at an interval of 2 weeks. Secondly, Group B patient post-operatively received the usual care. Well, usual care, we must know what is usual care after DVIU. There are some centered oriented usual care is established. Otherwise, no such recommendations were given in the books for usual care. Usual care is urethral dilatation. Urethral dilatation, two types of urethral dilatation. Initially, we encourage patient to do ICSI, intermittent self-catheterization. So intermittent self-catheterization post-DVIU is several times in a day. Like patient have to perform self-catheterization under local xylocaine use. Then with according to the symptomology and some lab investigations, flow of the patient is monitored. If patient had to handling any symptoms of pain, patient complains of splitting of urine, chowding of urine, and increased frequency or multiple symptoms, then patient has to underwent urethral dilatation. The urethral dilatation is a procedure which was done by the doctor itself. And the urethral dilatation, there is no set protocol. These are based on the investigations and symptomology. So once in a week for at least 3 weeks. You can say once in a week for at least 3 weeks. Then according to the symptoms, such type of dilatations will be performed accordingly. Americans believe on the symptoms with uroflowmetry. Uroflowmetry is a tool to investigate the flow of the patient. So according to the flow of patient, they used to perform the urethral dilatations. So efficacy was determined in both groups at 6 months post-surgery. Data analysis was SPSS 25 used, mean and standard deviation calculation for quantitative variables, frequency and percentage calculated for qualitative variables. Efficacy compared by chi-square test and p-value was considered as 0.05 less than or equal to. Efficacy outcome was stratified per patient age and stricture characteristics, duration, site and length. Post-stratification chi-square was used to see the efficacy. So these were the results. As you can see, the bulbar urethra. 44 multiple questions were raised on this chart. These results, like why you have enrolled the patient of benign urethra, otherwise we don't use to perform DVIU on penile urethra is not recommended in penile urethra. And then secondly, you have used the terminology for prostatic stenosis. Otherwise, we have learned that there is no stenosis in the posterior urethra. Posterior urethra, there is a stenosis of basically the tissue of prostate and bladder neck. So my study was mainly concerned about the vulvar urethra and 44 patients in group A and 45 patients in group B. So results was efficacy seen in 80% in group A who received oral steroids for a period of 3 months and tapering to the 6 months, and results was concluded on after post-surgery 6 months. And 53% in the group B, they were not on the oral steroids, and these patients were on urethral dilatations. And you can see the vulvar urethra p-value is 0.001. This p-value basically represents the study and the results. So, majority of the stratified variable shows significant differences in efficacy between group A and group B. Having a stricture in prostatic and membranous urethra and stricture less than 4 month duration didn't show a statistically significant difference in outcome between the both groups. The strength of our study was RCT, appropriate follow-up, and standardized data collection by trained data collectors using pre-coded tool. Some of the limitations are we assess the efficacy of steroid at a fixed dose, like 6 mg OD. Then only oral route of administration of steroid was implicated in this study. Otherwise, intralesional steroids are also used, and there is a big recommendation for such type of treatment post DVIU. So the conclusion was oral steroid after optical internal urethrotomy are effective in reducing recurrence of urethral strictures. We would recommend the routine use of oral steroids post DVIU for prevention of stricture recurrence. There is a need of more vast research studies assessing the efficacy of steroid at different doses with various route of administration. Well, thank you, and I must expect multiple questions, especially from Dr. Iran. Like, as this paper was presented in Eurocon, and I was the only one who stand on my the rostrum for a period of 20 minutes. Otherwise, we got only 10 minutes to present our case.
Yeah, I have a question. There is you have mentioned an exclusion criteria. Patient taking steroids are not included in your study. But on the other hand, you are giving steroids to the patients.
Well,
that's why the data is
Already patients are taking steroids.
उसको तो शामिल नहीं किया
तो एक्सक्लूड करना है,
उसको नहीं करना।
तो उसको मतलब देखें ये स्टडी बेस करके वो क्राइटेरिया में फॉलो नहीं करें क्योंकि हमने पेशेंट को सब्जेक्ट करना है स्टेरॉइड्स पे, ठीक है, और उसको स्टेरॉइड्स को रखा भी लो डोज पे। क्यों बाद में जो है ना क्वेश्चन ये हुए कि डिड यू मॉनिटर द साइड इफेक्ट ऑफ स्टेरॉइड्स द पेशेंट हैव? So my answer was like 6 mg steroid is not that much harmful dose for a patient.
I have a question. Your study is good as for the efficacy of steroids in urethral strictures. You have divided the patients into two groups, one with usual care, other with steroids. So the question is that how you manage to see the patients, the efficacy of the patients clinically, because you put the patients for 3 to 6 months. So what was the, you didn't elaborate it, what was the mechanism, what was the procedure to judge the efficacy of these patients, and how was accurate to check this efficacy, whether they were responding or not responding?
Indeed, it's a very good question. Very good question. This was the question which was raised by Mr. Matthew. He is a minister in the UK. He is a well-known urologist. My patient, ideal tool for efficacy to be checked is uroflowmetry. Otherwise, we also, in some cases, if uroflowmetry is inconclusive, we use to perform flexible cystoscopy as well to see the scar, to see the length of the scar. If then not possible, then we subject the patient to invasive investigations like retrograde electrograms, even MRI to some extent patient should be subjected for MRI as well. So in my study, I followed my patient according to the symptom. Like जैसे मैंने ये कहा तो then the sir was like, this is not the basic criteria for to patient to be followed according to the symptoms. So I followed patient according to the symptoms. There are three main symptoms, and these are diagnosed otherwise like कहते हैं कि अगर ये symptoms नहीं है तो ये disease होगी नहीं. Only symptom is voiding LUTs. Voiding LUTs contain the splitting of urine and showering of urine, and the stream of the urine is decreased, and patient came with intermittent urination with complaints of pain as well. So I followed patient according to the symptom. So this is not the basic criteria for to check the efficacy of the patient. Then secondly, why I did the patient followed on symptoms is because of the bulk of the patient. Like I couldn't manage the time to subject the patient for urethrotomies, subject the patient for flexible cystoscopies, back-to-back cystoscopies. Then after 2 weeks, he will definitely come to me that I have such type of symptom. Then again urethrotomy. फिर देखा जाए तो स्टडी भी जो है ना एक दूसरा रंग पकड़ती थी. कुछ पेशेंट्स में यूरोफ्लोमेट्री मैंने करवाई.
You kept a strong follow with the patients.
Yes, obviously.
Regarding the checking of these
Symptoms on daily basis even. On daily basis.
You call them in OPDs or you personally follow them?
Some of the patients they were personally itself were willing like my name is in the study. प्रूफ तो बना लिया था थोड़ा सा उनको मैंने, लेकिन most of the patients जो है ना they used to tell patient in phone like I have this type of symptoms, what should I do? लेकिन ज़्यादातर patient जो थे they usually came after 2 weeks, then 4 weeks, for just because if the symptoms are resolved then I have to taper the steroid dose as well. So for a period of 6 months I have tapered the steroids for 6 months. Patient was not using steroid and patient was not having complaint of voiding LUTs.
Or you have a good study. My question here, as you told here, mentioned here, is it a randomized control? Was it a blind or non-blind?
Non-blind. The patient, patient, I did the DVIU. I saw the patient. The patient was enrolled in my study. Then the patient was followed by symptoms, and they used to call me and told about their symptoms. So I think this is a non-blind study.
So the non-blind study have more fruitful. Our blind study should be.
Blind study.
I
don't have exact idea.
Because देखो यहाँ पे आपका वन साइड पे 2 पेशेंट्स होते हैं, उसमें स्टडी करने वाला, एनालिसिस करने वाला जब भी शामिल होता है तो कोई ना कोई अपना जो स्टडी का एम होता है प्रूफ करने के लिए कहीं ना कहीं क्लास होते हैं. When you are doing the non-blind, especially non-double-blind study, double-blind study करो तो study results are always considered as 100% true, because neither the patient knows about the study nor the doctor's study conductor knows about the study. So any study which is randomized, controlled, double-blind, even sometimes single-blind, patient alone or doctor alone, or even analysis people who are doing analysis of your data, they also don't. This is called triple.
Yes.
So ये तो सिर्फ randomized control है, इसमें human factor.
I have another question.
Yes, sir.
Steroids being the main therapy of this study.
Yes.
So its dose was fixed 6 milligrams.
Yes. And this is my limitation as well.
So how you can say that this fixed dose is effective in all patients? So is there any way to increase the dose in some patients? Or if there was any patient with complications of steroids, you observed for any complications, you followed the patient with complications?
Well, you being a medical specialist very well know about the doses of steroids. As far as 6 mg OD is concerned, this is less harmful for side effects to be seen in patients. I have not seen a single symptom of steroid side effect in patient who are using in my studies these patients. So, what was your second question?
I said, did you follow for any patient?
I told you there was no message there. Sorry ma'am, fixed dose इसलिए choose की कि patient was initially हम जो DVIU करते थे, DVIU का basic concept ये है कि this procedure should be performed, ideally should be performed in a stricture, in a scar of length should be 1.5 centimeter, not more than 1.5 centimeter. Plus, there would be spongiofibrosis, less spongiofibrosis, not dense spongiofibrosis. These patients were I told you the stricture, urethra stricture के जो patient हमने जो enrolled किए, तो these were the criteria जो उसमें हमने enrolled किया. अब dense जो उसमें spongiofibrosis होगी, length ज़्यादा होगी, तो वो study में ही नहीं आता. तो उसमें ये छोटी dose 6 mg effective भी नहीं होगी. So less than 1.5 centimeter of stricture, जिसमें DVIU हुआ ही पहली दफा हो, दूसरी दफा का DVIU भी नहीं, क्योंकि फर्स्ट DVIU के बाद सक्सेस रेट इज ओनली 68%, सेकंड DVIU के बाद सक्सेस ओनली 35%, सेकंड DVIU के बाद थर्ड DVIU का रिजल्ट इज 0. सो पेशेंट को बार बार DVIU का सब्जेक्ट भी नहीं करना. देन वी हैव टू चेंज द मोडालिटी ऑफ ट्रीटमेंट. एनास्टोमोटिक उसमें यूरिथ्रोप्लास्टिस में जाते हैं या फिर ऑगमेंटेशन यूरिथ्रोप्लास्टिस में जाते हैं. जी मैडम.
मेरा क्वेश्चन ये था कि जैसे प्रेडिस्टोन की टेबलेट है वो 5 mg की है, फिर आप 6 mg कैसे सीख रहे आप?
सवाल तो ये होता है.
2.5 and 2.5. डेक्सामेथासोन क्या है मैडम? वो 6 mg है. ये 20 में डेक्सामेथासोन यूज करते हैं.
मेरा 4 mg आती है.
वो 4 mg.
4 आगे 5
4 mg.
5 mg.
ये तो